We're live, Kate. On you go.
Lovely. So I was just giving you a couple of seconds for everyone to enter the room. Lovely. Okay. Thank you for joining us on this tea time talk on critical appraisal for prosthetists and orthotists. My name's Kate Chohan. I'm a clinical specialist orthotist and I've undertaken a master's degree in clinical research methods, and I'm currently undertaking an NIHR Health Education England predoctoral clinical academic fellowship, and I'm also current acting chair for the research committee for BAPO. So hopefully I've got a few research skills under my belt, and I hope to share some of these with you today. We've got an hour, so it's a bit of a whistle-stop tour of clinical appraisal, but I felt we needed to give you the background of what is evidence-based practice first, go through how to find the clinical evidence, run through the priorities of critical appraisal. I'll show you some tools that can help with critical appraisal, and then we can think about some of the profession-specific considerations. Now, when you're working in clinic, quite often you will come across things that you don't know about, and that's perfectly normal, and we have to admit when we don't know everything, and we have this desire to fill in the gaps in our knowledge, and that's where evidence-based practice and critical appraisal can come in. So evidence-based practice is the combination of the best scientific evidence that's available. It's also your clinical experience, so it's the skills that you have and that you're able to use in your clinical practice, and the values of your patient. So the patient's needs quite often can be different to what you're hoping to provide to them. So we need to take all of that into account when we're making our clinical decisions in clinic. Also, though, we need to consider the resources and our local priorities. The priorities that are available to our clinical services and the materials and the tools that we have may limit what we're able to provide to the patient. In the same way, the evidence that's able to back it up, our clinical experience and the patient's values may change what we're hoping to prescribe for our patient group. So you've found that you've got a gap in your knowledge and you want to learn more. You need to find the information. So how do we do that? So first, we need to ask the right question. So we're in clinic and we've found that we've got this gap. So we need to make sure that we've got a really clear, focused research question that we can search for the information that we want. So we need to focus that by the population that we're interested in. Are you wanting to find out about a specific intervention? Do you know if you're trying to compare two different devices or materials or treatment methods to see which is the most appropriate for your patient? And do you know if there's any particular outcome measures that are important? So we need to develop a really clear search strategy. Other methods are, so I often use PICO, population intervention, comparator and outcome, to try and identify my patient group, my research question, but there are other search strategies that you can use depending on whether you want to look at patient views and experiences. You can use SPIDER. There are generic frameworks, so SPICE, PICTO for diagnostic texts, ECLIPSE for health policy, and PECO for etiologies or risk factors in treatments. But if you have a Google and have a look, they'll be able to give you more information about those other search strategies. So once you've focused your question, you need to try and find that best evidence. So how can we find the information? Where is it available? So the first thing that I would recommend is making friends with your local healthcare librarian. Most hospitals have a healthcare library and they are great at offering advice, and they will help you with developing your search terms and for generating your search. but only if it's for clinical use and not if it's for academic practice. So if you're a student, you can't get your local librarian to help you, unfortunately. I would recommend everyone gets hold of their Athens password. So if you've got an NHS email account, that's really easy. If you haven't, you can still get it with a company email address. You just need to jump through a few hoops and to evidence that you work for an NHS trust, but it's not difficult at all. So you've developed your question and now you want to start your searches. So you need to expand on all the terms that you've got in your research question. So you use synonyms. So for children, you could do babies, young people, and expand that out as far as you can go. You can use wildcards and truncation so that you can change a letter out in a word so that you can get Americanized spelling, or if you wanted to look for orthotics, you can take off, and orthoses, you can take off the end of the word and use the star to truncate the word. Proximity operators are very useful. You can ask for two words together, so make sure that you've got, so a lot of my research is into pectus carinatum, so I always ask for pectus next to carinatum. And you can expand and explode the terms using the search engines, also use mesh headings, which are part of the search engines. And then you can combine your searches using Boolean operators, so your and or terms. You can limit for only in humans, you can limit for only in English. And this should give you a nice targeted research search strategy and find you some good information. Now, you should always use a number of healthcare databases. Don't rely on one alone. If you use Medline, you'll only find about half of the research that's available. So it's recommended that we use Embase, Medline, Web of Science and Google Scholar at a minimum. As we work as allied health professionals, CINAHL is always a good one to add in there as well. And there is often only a small overlap between the databases, so it is really good to use separate search strategies. Your librarian will tell you that different databases have different algorithms, so it's worth tailoring your search to the specific strategy. So if you're not finding something, try and change your wording a little bit. You might find some more articles out there. The easiest website to use to find the healthcare databases if you're not linked to a university is the hdas.nice. So that's run by the NHS and enables you to search all the healthcare databases either separately or simultaneously. I'd often recommend doing it separately because they do use those different algorithms and you can tweak your searches so that you're picking up the greatest number of papers. So now you've completed your search and you've got some output. So we've got a list of journals now that we want to, and articles that we want to find. I usually export my results to Excel, and it allows me to track the papers a little bit easier. It also means that we can sort them and then remove any duplicates, so you're not looking at the same paper twice. And you can check all the titles for relevance, and you should be checking the titles and the abstracts for relevance at each stage of the search process, because that's going to make sure that your search strategy is appropriate and you're not missing anything, but you're also not pulling down lots and lots of journals that have no relevance to your clinical area at all. So you've found your papers, you've removed the duplicates, and you've checked the titles for relevance. So now we need to start appraising the evidence that we've got and have a look and see what we've found. Critical appraisal is the skills that allows us to find and check that we've got the best evidence. We're assessing everything that we read for its validity and its importance. We're examining all of the research to check that it's trustworthy and it's relevant in our context. So we can have a look at the research in their context, and then we can determine whether we feel that the research will be appropriate to use in our context. We can determine what the research is trying to tell us, and we can decide how useful it will be, but we can also decide if we believe the research. Just because research has been published doesn't mean that it's always high quality. So we need to make our own assessment of everything that we read, which we should be doing in our daily life as well. So we've now got a pile of papers, which we need to read. So the first thing we need to do is read our paper quite carefully. So we need to have a look at the title and see what claims are made within that title. And then if we think that it's worth continuing, do a quick read of the full paper to get a sense of the content. Sorry. And see if we feel that it's worth continuing. And then once we've done that, we need to read each section carefully, line by line, and decide whether critically appraise each step of the research process. And we do need to consider where the journal article or the paper has come from. Is it peer review? Is it an opinion piece? Do we have conflicts of interest? Is it written by someone who's employed by the manufacturer, or is it done by a research team that's completely separate? So it is good to read all the small print around the side of the journal as well. So once we start to read the introduction, we need to make sure that the researcher has identified where the knowledge deficit is. So why is this research important? They should identify what's known in the area, and then they should argue balanced an argument for the different interventions. So there should be a question of why one may be better than the other, but it should be a nice balanced argument. And try and assess whether the author's trying to lead you to one way or the other. So the language can be quite leading. So if the author's saying that they're describing research, an intervention or a research output, then they could be quite neutral in that area. If they're discovering something, then they're sounding very positive about it and they're leading you to think positively about the intervention in question. Whereas if they're claiming a finding, then they're potentially more negative about it. So it is possible for the researcher to lead us to try and to a conclusion very early on in the paper. Then we need to assess the study design. Has the researcher used an appropriate selection of study design to answer the question? And have they used the research methodology appropriately? Sometimes you can, especially in areas, so if you're trying to work out patient experience and patient opinion, qualitative methods can be quite difficult to follow and to make sure that these methodologies have been used correctly. So it is worth trying to understand the research methodologies as well as understanding the research outputs. So we have the hierarchy of evidence. So that takes us from expert opinion up to systematic reviews and meta-analyses. So I'm going to have a little bit of detail about some of the methodologies, but not all of them, just to give you a bit more understanding. So if we're looking at reviews, the highest level of review is a systematic review. Now, a systematic review is considered primary research. It uses a research protocol with inclusion and exclusion criteria, as you would do in any other research. It allows meta-analysis, is the combination of the research findings using statistical methods to pull the information. And this is very high quality data and allows us to develop very strong understanding of the research and research findings. A methodological review looks more at the methods of how you find the data. So it isn't really looking at the findings of the research at the end, it's looking at the methods used to answer a specific question. A scoping review is looking at the available data in a specific area, but is getting the lay of the land. And a traditional or a narrative review is can be systematic, but is reporting the evidence where the case numbers may be smaller. The findings are too separate, so they're not homogeneous. We can't put them together to do the meta-analysis and get the statistical findings. Then we have randomized controlled trials. Randomized controlled trials use two groups of matched patients or participants to see if the investigation is due to change in the outcome is due to the change in the intervention, or whether it's due to chance. These can be blinded so that the participants don't know which group they're in, or the researchers don't know which group the patients are in, so they can be blinded at various stages. A randomized controlled trial is very popular, it's very robust, it reduces bias, which is one of the problems that you can see in research. There can be bias at multiple levels, and it accounts for confounding, and confounding factors are other things that may be causing the change that we see rather than the intervention. So we have Rambo. Now Rambo is the thing that stops bias. So we need to be really careful at all of these levels. So when we're looking at recruitment into our study, we need to make sure that we've got balanced groups, that we've considered all the confounding factors, and we've made sure both groups are matched as well as we can. We need to make sure that the allocation into the groups is appropriate, that we've got everyone participating in the research that needs to be there. We need to maintain our participants. We don't need to lose anyone. We need to make sure they stay in their allocated groups. If there's any crossover, we need to know what's happening and why. We need to make sure that the blinding's done carefully and properly, so there's no cheating. And we need to make sure all the objective measures and processes have been done correctly, so that all the research assistants, all the researchers, anyone working in the study has been properly trained to do all of the measurements, all of the treatments, so that everyone in the study is getting exactly the same experience. Now, at University of Oxford, they've developed this bias tool. So they've managed to pull together all the different level causes of bias in research. I'd take a note of the link at the bottom because it's really useful for keeping an eye on what these biases are, and it gives you a little bit more information on all of them. So that's our randomized controlled trials. Other research looks at surveys. So when we're looking at survey data, it's always worth checking the actual survey questions. They will always be attached to the article. They might not be reported in the main write-up, but they'll be separate. So have a look. Are all of the questions really clear? Are they open-ended? Are we leading the participants towards one answer or the other? Sometimes the survey can be a bit ambiguous and can be open to interpretation. So you need to make sure that there is no ambiguity in the questions at all. Now, it's important that survey data is anonymous, especially in a very small clinical area. If there is any data that could be reported in a paper that's in a very specialist area, giving, say, geographical data and condition data, then there is a chance that people could be identified, and that's not appropriate. And we need to make sure that the methods of data collection enabled all the potential participants to take part. So having a questionnaire that's online is great. It should make things easier, but unfortunately, not everyone has access to online tools. So we need to make sure that if we're trying to get a specific patient group, that we've thought about all the ways that they can be accessed, and that would be a limitation of a research project. Also, when we're looking at that method section, we need to make sure that we've got a sufficient sample size. We need to make sure that they've made all of the methods very clear, and we need to make sure that that sample is appropriate to the question. So one of the ways we can do that is by having an appropriate sized sample. We need to make sure that the researcher has done a power calculation. So this would be done by a statistician who would have a look at all the research question and the demographics and would build the calculation. So we need to have a look at two things. So there's a clinical difference and there is a statistical difference. So they can be different. If we have a large sample size, we were able to detect small differences in the intervention or the outcomes. But if the effect size is small, we need to make sure we've got a big sample. If the effect size is really big, then we may be able to get away with a smaller sample. So then we need to look at the demographics of our patients. And I think this is particularly important in prosthetics and orthotics research. Is the sample representative of the population that we're hoping to investigate? Have we got the right age? Do we know the levels of activity? Do we know their functional ability? Do we know their weight? Do we know their muscle tone? Do we know their ranges of movement? These are all things that will really change the outcomes. And if we don't know them, then we're making big assumptions about the results at the other side. So we need to make sure we pay attention to those details. But then there's other detail. Are we testing at the same time of day for all of the participants? If we're testing at the end of the day, some participants are going to be overtired, and that's going to change things like energy expenditure or fatigue. So we need to know this, and we need to know that the methods used are always appropriate. Are we using the most up-to-date and validated methods for measuring range of movement? If we're using questionnaires, are we using a validated questionnaire, or is it a questionnaire that's been written by the research team? Are we using something that's disease specific, or are we using something that's generic and might not be sensitive enough to pick up changes? So have a look at all the methods and consider whether you think they're appropriate for the question that you're trying to ask. And then we need to move on to the results. So if you've read through all of your papers so far, we should really understand what's happening. Now, your results and your research findings should be reported in a very objective manner. We need to have a look to make sure that the results are very clear and there's no ambiguity in the output. And this is where we start to get lots of statistics, and things can get a bit complicated if you're not sure what's happening. So we need to have a look at the clinical significance of the results. Have we got a treatment response? If we have, how big is it? In which direction is the treatment response? Are the results precise, or are they very varied? Do different participants respond in lots of different ways? And do you think that the results that we've found are useful? So is the change that we're measuring enough for us to recommend a change in our clinical practice? So, for instance, if we're looking at medication, we can see that a drug for colon cancer can reduce the risk from one case in 5,000 to one case in 10,000, which, if we're looking at relative reduction, is 50%. So that's a massive difference. But if we're looking at absolute risk reduction, so we're looking at the whole population, it's a reduction of 0.001 percent, or no, it's a reduction of 0.01%. Yeah, too many noughts, sorry. But so we need to know the difference, and we need to know the clinical difference as well, not just the absolute difference. So we need to check that the results quantify chance with the results. We need to know that we understand the direction of the results. We need to understand the magnitude of the results, and we need to be able to assess whether they're relevant to our clinical population. And we've got to look at those outcome measures as well, again, to see if we think they're appropriate for the questions that are being asked. So when we're looking at a randomized control trial and we're comparing two groups, so an intervention group and a control group, we can look at it in either as a ratio or as a difference. So if we're looking at a ratio, we've got the intervention, so the change in intervention divided by the change in control. And if the outcome's 1, so that means that there was no change. So the intervention had no change on the outcome. And this can be your risk ratio, your odds ratio, or your hazard ratio. Now, if you're finding that the difference between the groups is less than 1, it means that the event that we're measuring, the outcome that we're measuring, is less in the experimental group. And if it's more than 1, then it's more likely to occur in the experimental group. And obviously this makes a difference whether we're measuring something positive or negative. So less falls would be great, as would be less heart attacks. You need to think about the question when you're looking at the numbers as well. So then we can look at the absolute numbers. So that's the difference. So that's the intervention minus the control. And now if there's no difference between the control groups, we've got a number of 0. So that would be no treatment effect. And if it's minus number, we're less likely to see the outcome occur. And if it's a positive number, we're more likely to see an outcome occur. So that gives us a standard mean difference. We're looking at risk difference and absolute risk reduction. So those are whole numbers, absolute differences. But we can work those out as a percentage, and that gives us the absolute risk reduction is seen as a percentage. And if we've worked that one out, we can then find the number needed to treat. So that's often recorded in your research papers. So how many people do you need to give a intervention to have one person have a specific outcome? So the example here is aspirin. So the mini aspirin for having a heart attack. So to see one extra occurrence of prevention of death, and I think it's 500 people have to take an aspirin to see a reduction in death. But the risk of a negative effect is much smaller than that, so it's worth doing. And when we're looking at our numbers, we need to track our patients through the data. So whenever we do research, it's not unusual to lose participants. And we need to understand what happens to those participants through the research study. So how has the researcher dealt with this dropout rate, lost follow-up, or patient swapping groups? So if they've gone from the intervention group to the control group, or the control group to the intervention group, if that's possible. They need to make sure that they clearly report that missing data. And if you look at the tables, you can often follow. So they'll report the number of participants in each section, and we need to keep track of that because we need to make sure that that number is always greater than the number in that power calculation that we saw at the beginning. So we've got an understanding of the effect of the data, and then we can have a look at the distribution of the data to see how confident we are in the results. So we would expect all research data to hopefully have this normal curve, which enables us to measure the standard deviation. So we would expect that 95% of the data will be within 2 standard deviations of the mean. And so you can see that on here. And that then leads us into confidence intervals. So this is the range with which there's the true size of the effect. So we're not quite sure exactly where in there the range of numbers that we are, but we assume that we're somewhere in the middle. and the interval between which we're certain that the results will be between is within 95% of certainty. So you can see one line, the length of the line gives us the range, and the dot in the middle gives us our confidence. Another thing that's reported in research is a correlation coefficient. So we're looking at the relationship between two variables. So we're not always looking at one variable. Quite often there's multiple variables that could change the impact the outcome for our participants. We've got to be careful. It does not infer a causal relationship. And it also can be distorted by outliers. So if there are participants that do not respond in a normal way, they're worth going back and having a look. So you might find that their data doesn't make sense in what's happening. They could not, they might not match the groups at all, in which case, if you feel the researchers feel that they shouldn't be included, they may remove the outliers from their data analysis. Then we've looked at our p-values. So I think we all looked at p-values when we were at university. So if we've got a p-value of below 0.50, it's considered significant. So that means that there's a 95% chance that the effect has been, the outcome has occurred because of the intervention. But there are debates at the moment to say that we should increase that to 0.005 because anything else would be considered suggestible. But there are a variety of arguments on that, and I think it's something that you have to have a look at. You need to consider the patient groups, you need to consider the sample sizes. So that was all looking at sort of experimental research, but then we've got, if we're looking at our systematic reviews and our meta-analysis, there are things that we need to consider too. So we don't just accept that research either. So one of the things that is a factor is homogeneity. So that means the similarity between the studies that are included in the meta-analysis. So they should all be reasonably similar. So there are tests that you can do, Q or I squared, which gives you a score, which will be reported within the study, which gives you an idea of whether the studies are similar enough. And this could be due to sample size or research methodology, participant recruitment. So a study could be in different age groups or different conditions, different countries. So it's something to have a look at, and then they might pull the data to do subgroup analysis to pull the data that is the most homogeneous. And when they're reporting your meta-analysis, we tend to see forest plots at the end of studies. So this is a forest plot that we're showing you. We can see that we have got confidence intervals. We've got these long lines with squares in. So the smaller the square, the smaller the sample size. So we would anticipate that a large confidence interval would indicate a small sample size, and a large sample size, due to the power and it would focus the results, would give us a smaller confidence interval. The blue line and the diamond is the combination of all of the research studies, and the size of the diamond gives us the sample size. Now, 2 of the studies pass the line for 1. So we're looking at an odds ratio. So that means that some of the participants did not get, the outcome did not occur, whereas it did occur on the right-hand side of the line. So that's the line of treatment effect. If you're on the line, it means that there was no treatment effect. It was less likely to happen to the left-hand side of the line and it's more likely to happen on the right-hand side of the line. So that gives us an estimate and a graphical representation of the data and can be quite useful for understanding. So we're going to move on to the discussion now. Now the discussion should explain how and why the research builds on previous research, and does it agree or disagree with the findings. It should be very clear about the limitations of the findings. It shouldn't try and brush anything under the carpet. So the limitations that you've found, it should discuss. It should discuss how the clinical findings and the research findings could be useful in clinical practice. But again, like in the introduction, we should be beware of the language used because it can be leading. So then we're looking at the conclusion. Has the researcher made generalizable comments? So do you think that the research data was strong enough to reach the conclusions that they're stating? So I often find that the researcher is very strong, that they're able to generalize their results and their conclusions are very valid, but actually when you pull through the data, yes, it is positive and it is finding, you're able to see the intervention has changed the outcomes, but maybe it's not quite as strong as they're suggesting. We need to make sure that that sample size was still large enough to make those conclusions, and that's following the number of participants through the data and making sure that they've not dropped out. And did the study allow for correct identification of those findings? Could they have used a different methodology maybe? And the most important questions I think that you need to ask are, can you transfer those findings to your patient population? Are they transferable? Are they generalizable? And do you believe those findings? Is that research believable? So you need to do this for all of your papers. It's a lot of work, but I do think it's worth it. And once you've done that, you can start to act on your evidence. So you can pull all of your information together, and that's when you can start to write your clinical protocols and your guidelines for clinical practice, so that you make sure that everything that we're doing in clinic is evidence-based and is up to date. And I would make sure you've saved your searches because things are coming out all the time. And if you can just press search again to check on your data, it makes life a lot easier. And with evidence-based practice, they suggest that we are always evaluating what we're doing. So one method is using the plan, do, study, act cycle. So we're planning to ask objective questions about our clinical practice. Then we're changing what we're doing and we're observing our findings. So we're studying on that, then we're acting on the changes, and then we're going to go back to that planning stage. So things like clinical audit can help with that. I think patient advisory groups are very useful. Oh, sorry. And friends and family reporting, sometimes that can highlight areas where we could improve our practice. So I mentioned at the beginning that there are tools that can help you with your work. So the one that I use the most is the Critical Appraisal Skills Programme, or CASP. They have specific checklists for different research methodologies, so you can choose one that's most appropriate for you, as does Joanna Briggs. And then we've got the Centre for Evidence-Based Medicine worksheets, Evidence-Based Medical Toolbox, and the SIGN Critical Appraisal checklists. So they all allow us to work through the documents, asking really clear, focused questions about the methodology, and hopefully I've gone through some of the information so that the questions make a little bit more sense. And then in prosthetics and orthotics, I think we often are missing some of the information. So one of the specific things that we need to know is there enough detail for us to transfer the research findings to our patient group? I often find that they talk about an AFO, but they don't tell us the materials, they don't tell us the trim lines, if the footwear is involved. We also often don't have enough information about the presentation of the participants. So it's very, very difficult then to make any strong conclusion about anything that we've found, that we've read, but also it's very difficult to move that information into our clinical practice. So that's something we can hopefully encourage researchers to change and to move forward with. So that's everything that I wanted to cover today. If you did have any questions, you can email me, or I'm on Twitter at Kate Johan. We at BAPO have now got the research committee, and we would love to be able to support any prosthetists or orthotists who are interested in taking their first steps or their second steps or their third steps into research. We've got members with different levels of skill and support in prosthetics and in orthotics, in higher education and in clinical practice and clinical academic work. So hopefully we'd be able to support you in different directions. We have also got to remind everyone of the wonderful P&O Day. That is on Wednesday. So if you have any information that you want to share with us, any photographs, send them to Lynn at lynn.rowley@bapo. And we'll be having a montage of all the lovely photographs and information from everyone. And not to forget our conference that is on the 8th and 9th of October. So registration is open. And I can see that there is a question.
I was just about to say there was a question. I don't know if you could see it.
Okay, so I think clinical reasoning is a very large part of evidence-based practice. I don't know, can everyone see the question?
Should be able to, yeah.
Yeah. So I think that you need to include your clinical reasoning with evidence-based practice. I think what I've said about the confines of the research population and how difficult it is to extrapolate, and with the comorbidities, I think prosthetics and orthotics, but potentially more orthotics. I think our patient groups are very complex, and it's very difficult to extrapolate, as you say, the research findings from one patient to another, because they're so different. But I do think that they give us different tools and different information that we can use. So it is worth making sure that we're up to date with the evidence. And the tools do help you to do it faster. There is a lot to think about when you're doing your critical appraisal, but using the tools makes it a much faster process than working through it on your own, because it's much more focused. Lovely. Any other questions?
They're all gone quiet today.
Yeah. Was a bit of a whistle stop.
Always a hard subject to cover. Thank you so much for your time tonight, Kate. Really appreciate it. And you've given everyone your contact details, and I'm sure they'll get in touch if they need to.
Yeah.
And nobody's typing, so I think, yeah, chat's empty, Q&A's empty.
Lovely.
That's brilliant. Thanks again. Take care.
Thank you very much.
Bye-bye.
Bye-bye.